So, welcome to this session on vasculitis. For the next hour, we will explore the critical intersection between rheumatology and cardiology, focusing on how systemic vascular inflammation can affect the heart. I co-chair with Dr. Bratis, and I think that we are both privileged to have two outstanding experts with us. So let's begin, and we will start with Professor De Luca from San Raffaele Hospital in Italy, who will share the rheumatologist's perspective on vasculitis. Professor De Luca, please go ahead with your presentation.
Hi. Good morning, everyone, and thank you for the kind invitation. It's a great pleasure for me to be here. And please let me know if you can see the presentation.
Yes, of course.
Okay, I will share with you two cases of vasculitis with heart involvement. I will start with two cases of small vessel vasculitis, two phases of the same disease. And then if we have time, it's up to you. Just please tell me. I can share also a third case on a patient with a large vessel vasculitis. So the first one is a case of a male, 51 years old, non-smoker, with a history of asthma since 2021, and findings of lung nodules at HRCT scan performed in 2022. He also had a 25-year history of hypereosinophilic syndrome, which can be complicated by several organ involvement, including heart involvement. The clinical onset was quite dramatic in this case. He suddenly developed chest pain, in fact, like in June 2023, with symptoms and sign of heart failure with lower limbs edema, shortness of breath, and dramatically depressed heart function requiring hospitalization in the emergency department. So echocardiography showed a globally depressed left ventricular ejection fraction lower than 20%, and an intra-aortic balloon pump was required for mechanical support of circulation. Coronary angiography was negative, so coronary 3 was unaffected. Then, since the history of hypereosinophilia and the dramatic onset with depressed left ventricular ejection fraction and unaffected coronary 3, an endomyocardial biopsy was performed, showing an eosinophilic myocarditis, so with diffuse infiltration of the myocardium by inflammatory cells, mainly eosinophils, but also macrophages and lymphocytes. It was suspected with an ANCA-related vasculitis since the history of asthma and hypereosinophilic syndrome with hypereosinophilic myocarditis, but ANCA were tested negative. This was not surprising anyway. A diagnosis of ANCA-negative, ANCA-related small vessel vasculitis was made, and basically he was diagnosed with eosinophilic granulomatosis with polyangiitis. And as you know, ANCA vasculitis could be ANCA positive or ANCA negative, and they are quite different characteristics. Sometimes ANCA negative vasculitis could be associated with eosinophilia that the patient had, asthma that the patient also had, as well as lung infiltrate and cardiomyopathy, and this was the case. He also had a peripheral neuropathy that emerged later in the history of this patient, but focusing on characteristic of ANCA-negative vasculitis, the patient had 4 of the main clinical findings commonly in this clinical scenario. After a few days, cardiac magnetic resonance was performed, showing a left ventricle dimension within normal limits, with preserved parietal thickness, but a moderate depression of global systolic function with an ejection fraction of left ventricle 38% for diffuse hypokinesia. T2 stir sequences show a diffuse irregular stria of myocardial edema with higher intensity in the posterior, inferior, lateral, and septal walls from base to apex. And LG sequences show diffuse endocardial fibrosis involving also papillary muscles at the basal right ventricular segment, as you can see in the shown by the white arrows, associated with large endocardial hypointense components as for thrombotic alteration, the largest indicated by the yellow arrows at the inferior and inferoseptal mid-basal level. Here, other images of LG sequences show diffuse endocardial fibrosis. Mapping were also performed, showing an increase in native T1 mapping, 1,120 milliseconds, and increase in T2 mapping suggested for diffuse myocardial edema. T2 mapping was 63 milliseconds, and even an increase in extracellular volume, 34%. The patient was treated with pulse methylprednisolone 1 gram for 3 consecutive days, then prednisone 1.5 milligram per kilogram per day, then tapering in 6 months, IV cyclophosphamide and mepolizumab, which is an anti-IL-5, so active on manifestation dominated by eosinophils. And considering the dramatically depressed left ventricular ejection fraction, an implantable cardioverter defibrillator was also implanted for primary prevention. I won't show you the follow-up of this patient because the focus of these two clinical cases is the different possible presentation of the same disease. But just to let you know that after a couple of years, the patient is going well, is on maintaining immunosuppressive therapy with 2 grams per day of mycophenolate and still on mepolizumab, 300 milligrams subcutaneously every 4 weeks, free of steroids. And no major cardiac adverse events occurred during these 2 years of follow-up. The second case is a female, 53 years, non-smoker. She also had a history of asthma, 25-year history of asthma, and hypereosinophilia, which was first detected in 2018 and clinically manifested with urticaria rash. She came to our attention as rheumatologist for arthralgias, and she also had the lower limbs paresthesia. But while asked, she also referred a history of nasal polyposis. So again, she was suspected with ANCA-related vasculitis because she had asthma, hypereosinophilia, polyposis, arthralgia, and paresthesia. ANCA tested positive in this case with a marked positivity of anti-MPO antibodies. And we performed a complete evaluation of organ involvement since ANCA-related vasculitis could affect multiple organs, including the heart and the central and peripheral nervous system. She had indeed a central nervous system involvement at brain MRI, documented by multiple areas of T2 hyperintensity in the brain. Electroneuropathy showed a multiple mononeuropathy, which was responsible for the lower limbs paresthesia she referred to us. And lab tests show only a slight increase in troponin T and NT-proBNP serum levels, but she was asymptomatic for chest pain, dyspnea, or palpitation. So she had no sign of possible cardiac involvement. If you look at the same picture we looked before, we are on the other side, in this case, in the side of ANCA-positive eosinophilic granulomatosis with polyangiitis, which could be manifested with eosinophilia that the patient had, chronic rhinosinusitis with nasal polyposis, and the patient had a history of nasal polyposis, asthma, which could be common in both ANCA-negative and ANCA-positive vasculitis, peripheral neuropathy, and possibly even a cardiomyopathy. Not so dramatic as the first case. Indeed, cardiomyopathy is more frequent in the ANCA-negative vasculitis, but the patient had a slight increase in troponin T and NT-proBNP, not explained by any other clinical condition. So we decided to perform, even in this case, a cardiac magnetic resonance. And in this case, left ventricle was dimensionally within normal limits again, and with preserved parietal thickness and almost preserved global systolic function. Ejection fraction was 52%. There were no areas of hyperintensity in T2 stir sequences suggestive for myocardial edema. And there was just a millimetric patchy areas of non-ischemic LG in the inferior basal wall, inferior lateral mid-basal wall, and mid-apical septum, as you can see here in this picture. Looking at mapping, we found abnormal values of T2 mapping, 60 milliseconds, suggested for slightly diffuse myocardial edema, and a slight increase in native T1 mapping and extracellular volume. As for diffuse increase of interstitial fibrosis, but they were just at the upper normal limits, 30% extracellular volume and 1066 millisecond native T1 mapping. She was treated mostly as in the first case with pulse methylprednisolone 1 gram for 3 consecutive days, then 1.5 milligram per kilogram per day, then tapering 6 months, cyclophosphamide, mepolizumab, and even plasma exchange, but because of the nervous system involvement. She had both central nervous system and peripheral nervous system involvement, other than cardiomyopathy. And we use in rheumatology the 5-factor score, which is a combination of 5 bad prognostic factors associated with ANCA related vasculitis, and she had 2 of them, so cardiac involvement and nervous system involvement, both central and peripheral nervous system involvement. So that's the reason why she was treated with such an aggressive therapy. And after 6 months, we had a follow-up, a CMR follow-up, showing a resolution almost complete of the diffuse edema demonstrated by the increase of T2 mapping, which decreased from 60 milliseconds to 52 milliseconds. There was also a really slight decrease of native T1 mapping. It was 1066, now it's 1054, and extracellular volume remains 30%. Of course, the millimetric patchy areas of non-ischemic LGE of the inferior basal wall, inferolateral mid-basal wall, and mid-apical septum did not vary at the follow-up CMR. We documented also a slight improvement of left ventricular ejection fraction from 52 to 58%. So these 2 cases tell us that AGPA, so eosinophilic granulomatosis with polyangiitis, which is an ANCA-related small vessel vasculitis, could be complicated by heart involvement. And in this case, we saw a double-headed coin. I mean, in the first case, we had a patient with a dramatically reduced ejection fraction, clinically manifested with congestive heart failure requiring intra-aortic balloon pump. And the diagnosis was made also thanks to endomyocardial biopsy, and CMR was positive for active myocardial edema. In the second case, we had a female patient with just a subtle onset, mostly asymptomatic, but with a slight increase in troponin T and NT-proBNP, with a preserved or almost preserved heart function, and CMR positive for subacute myocardial damage, so with only T2 mapping increase, but no still edema at conventional CMR. So these 2 cases, I think, are quite important for us because they tell us that we have to actively look for cardiac involvement, even in the patient with mild or even no cardiac symptom, if we are talking about a vasculitis as AGPA, which can be complicated by heart involvement. I would like to discuss with you this possible 2 different presentation of eosinophilic granulomatosis with polyangiitis involving the heart, and ask the moderator, please let me know if we have time for a 3rd case, which is a large vessel vasculitis. Otherwise, I will stop here. Can I go ahead with the 3rd case of large vessel vasculitis, or it's enough to discuss of these 2 cases of small vessel vasculitis?
Aliki, you're muted, I think. I think we've got enough time to move on with some more. Yes, please go on.
Yes, of course. That will be very interesting to see the large vessels vasculitis, not only the small.
That was even my thinking. That's the reason why I included this clinical case, which is a completely different case. It's a male, 81 years old, smoker, with a history of arterial hypertension with hypertensive heart disease. We know from a previous echocardiography that he had a bilateral enlargement and left ventricular hypertrophy, but with preserved left ventricular ejection fraction of 68%. No particular disease in his medical history, apart from a history of polymyalgia rheumatica, which is an inflammatory arthritis common after 65 years old, usually responsive to medium dose of steroids. So indeed, he was treated with a low dose prednisone for 4 years until complete remission. In December 2022, he had a COVID pneumonia, just with cough and no fever. Nasal swab tested negative in 10 days, so it was like a quite common SARS-CoV-2 infection. Anyway, a few weeks after COVID, in January 2023, he had a clinical onset with temporal headache, especially on the right side, And he presented a temporal artery tortuosity, as you can see in this painting by Piero di Cosimo, which is the portrait of Francesco Giamberti. It's a portrait around 1050, and it's probably the first manifestation, the first painting representing this disease. He also had scalp paresthesia and tenderness, and masticatory claudication and tongue claudication, and he presented loss in vision in the right eye. These are all suggested for a large vessel vasculitis called giant cell arteritis, and this clinical suspicion was supported by results of lab tests showing an increase of erythrocyte sedimentation rate and C-reactive protein, suggested so for a systemic inflammation, while autoimmunity was completely negative. All other routine blood tests were all within normal ranges. And a brain CT scan was also performed, since the scalp paresthesia, the tenderness, and the headache and the loss in vision. However, it was completely normal. So he was suspected for a giant cell arteritis, and before the rheumatological evaluation by his general doctor was started with prednisone therapy, correctly, as we should do in case even of suspected giant cell arteritis, because there is a high risk of loss of vision. So it was started with prednisone 25 milligrams per day, then tapered to 12.5 milligrams per day after 7 days. He comes to our first rheumatologic evaluation in February 2023. So the clinical suspicion of giant cell arteritis was confirmed, and so prednisone was increased, as usual in this case, up to 1 milligram per kilogram per day. So in this case, 60 milligram per day, and maintained for at least 4 weeks before tapering. Giant cell arteritis was confirmed by vascular ultrasound showing signs of active GCA, which are specifically the halo sign. The halo sign is a homogeneous hypoechoic wall thickening that is well delineated toward the luminal side, which has a good sensitivity and high specificity for giant cell arteritis, as well as the compression sign, which is the persistence at ultrasound of hypoechoic swelling despite the compression of the artery lumen with the ultrasound probe. And even this sign has a good sensitivity and a really high specificity for the diagnosis of giant cell arteritis. There were no neuro-ophthalmic complications, luckily. We also performed a PET CT scan because it's important to evaluate even the involvement of extracranial arteries, and PET CT scan showed the uptake of FDG in the thoracic aorta, subclavian arteries, and proximal tract of the abdominal aorta, so showing an active GCA with both cranial and extracranial vascular involvement. So giant cell arteritis is a large vessel vasculitis, commonly in the elderly population, usually treated with steroids and with other kind of biologic therapy that we will see. But at the time of this evaluation at our center, it was active a clinical trial for this clinical disease with guselkumab versus placebo for giant cell arteritis. So the patient was enrolled in this clinical trial, which was a randomized clinical trial. We later know that patient was randomized in the placebo arm, and this is important to understand the clinical evolution of this clinical case. So the patient continued to take steroids, gradually tapering of 12.5 milligram every 2 weeks, and randomized to receive, now we know, placebo. In April, 2 months later, after steroid dose reduction to 37.5 milligram per day, the patient had a disease flare with temporal headache, increase of C-reactive protein again, weight loss, palpitation, and without chest pain. And again, at temporary artery ultrasound, there was the halo sign, the compression sign positive. So the prednisone was increased again to 15 milligram per day. The trial was stopped, of course. We now know that the patient was treated with placebo. We decided to switch the patient to tocilizumab, which is an anti-6 receptor, highly effective in case of giant cell arteritis. because IL-6 is the most important cytokine in the pathogenesis of this large vessel vasculitis. So it was started in May 2023 with subcutaneous tocilizumab at a standard dose. But while he would, and the headache, the weight loss, and even the inflammatory markers had a positive trend during follow-up. However, in November 2023, he was still symptomatic for palpitation, so we decided to perform an altered EKG showing frequent ventricular ectopic beats higher than 2,800 per day, which were polymorphic, and polymorphic VBS could be suggestive for diffuse myocardial edema, myocardial inflammation rather than fibrotic scars. He also runs of non-sustained ventricular tachycardia were recorded at this altered EKG. High sensitive troponin T and NT-proBNP were within the normal range, quite surprisingly, honestly. He was treated by an rheumatologist, a cardiorheumatologist, with metoprolol 25 milligram twice, and flecainide 150 milligram per day, and ramipril. We decided just to reduce the number of VBS and to perform let's say, clean cardiac magnetic resonance as cleaner as possible. So the CMR was performed and showing a left ventricular dimension within normal limits, with increased parietal thickness of the basal inferior septum and diffuse hypokinesia, especially at the base, with mildly depressed global left ventricular systolic function. Ejection fraction was 42%. Remember that in a previous echocardiography in 2022, he had the left ventricular ejection fraction of 68%, because of the hypertensive cardiomyopathy. T2 stir sequences show focal area of subepicardial edema of the basal septum and of the mid-basal inferior junction point, as you can see by the white arrows. And in the same areas of myocardial edema, lead sequences show subepicardial and mesocardial LG in the inferior basal septum, anterior base, and intense component of subepicardial LG in the posterior junctional region, resulting in the focal parietal hypertrophy. Mapping were also performed, showing a remarkable increase in native T1 mapping, 1,340 milliseconds, and T2 mapping was 67 milliseconds, so suggestive for myocardial edema. We decided, since it's quite strange to have myocarditis in the context of giant cell arteritis, not so common, we decided, even considered the age of the patient, which is 81 years old. We performed an endomyocardial biopsy, which was suggestive for virus-negative myocarditis, showed a marked infiltration by CD3 positive cells and also CD68 positive cells, so basically lymphocyte and macrophages. Here you can see some hematoxylin and eosin staining, and the other staining showing the blue, which is the patchy interstitial myocardial fibrosis. So a diagnosis of virus-negative myocarditis in the context of giant cell arteritis, still on therapy with the anti-IL-6 tocilizumab, was made, and we added on tocilizumab therapy with mycophenolate mofetil, which is our conventional immunosuppressant that we use primarily in case of virus-negative myocarditis in the context of systemic autoimmune diseases. It was started at a low dose of 1 gram per day, associated with prednisone, which was increased again up to 25 milligrams per day, and tocilizumab, which was maintained. However, follow-up alters show again frequent ventricular ectopic beats higher than 6,000 per day, which were polymorphic with couplets and triplets. So, in keeping with as suggested by our cardiorheumatologist, flecainide was switched to amiodarone, maintaining metoprolol and ramipril. And we decided to perform a follow-up CMR, which is basically unchanged with respect to the first one. So despite the immunosuppressive therapy with tocilizumab and the addition of mycophenolate on top of tocilizumab therapy, and even the increase of prednisone therapy, showing again the same area of stir edema and LG, of course, as well as mapping. Here you cannot see the reported values, but are almost the same. So T2 mapping around 70 milliseconds and T1 mapping higher than 1,300 milliseconds. So mycophenolate was increased up to 2 grams per day. Tocilizumab was maintained, even still considering the central role of IL-6 in this disease, and prednisone was maintained at 25 milligrams per day, then gradually tapered. We prescribed a PET CT scan to evaluate extracardiac active disease, and now the follow-up is exactly right now. We are asking to you what will be the next step, even in your opinion, considering that we have a case of myocarditis in giant cell arteritis, which is not the most common situation. Looking at the scientific literature, there are only few cases of myocarditis, mostly acute myocarditis or myopericarditis in the context of giant cell arteritis, just single cases. One even from our group, 2021, which was a case of inflammatory dilated cardiomyopathy occurring in the context of giant cell myocarditis and giant cell arteritis. And it's quite surprising to have a myocarditis while the patient was on anti-IL-6 therapy, because IL-6 is central to both pathogenesis of giant cell arteritis and even is involved in the pathogenesis of myocardial inflammation. These are some preliminary data from mouse model of autoimmune myocarditis showing that IL-6 receptor inhibition can modulate immune reaction and myocardial collagen 1 and 3, as well as alpha smooth muscle actin production in experimental model of myocarditis at least. We have also some data, few data from clinical practice that anti-IL-6 should be effective in treating myocardial inflammation in the context of giant cell myocarditis. This is the case we published with Corrado Campochiaro 3 years ago, presented the case of a patient with giant cell arteritis, presented with markedly depressed left ventricular ejection fraction and areas of LG as well as myocardial edema in only slight myocardial edema at cardiac CMR, diagnosed with inflammatory dilated cardiomyopathy and treated with tocilizumab, mainly for the giant cell arteritis, but with positive effect even on the follow-up CMR, with an increase of ejection fraction from 35 to 45%, and even a reduction of the septal LG presented at the baseline CMR. So it was quite surprising in this case to have a case of myocarditis in a patient already treated with tocilizumab. So the question in this case is just to the audience, what's next from therapeutic point of view? I think I concluded my presentation. I would like to thank you again, the scientific committee, and all of you for your attention. Thank you.
The three cases are very interesting. Regarding the last case you presented with large vesicular vasculitis, one question I have, you did a CMR at the beginning, screening the patient when he was diagnosed? No.
No. We had the CMR when he presented with when he still had palpitations, and the Holter EKG showed high number of ventricular ectopic beats which were polymorphic, and runs of non-sustained ventricular tachycardia were recorded. But we didn't expect a myocarditis in the context of GCA, so it was a smoker, 81 years old, so we expected to with systemic hypertension, we expected to find something else, not myocarditis in the context of a GCA.
I think that routine imaging for asymptomatic patients isn't standard, we know that, because data are very limited. However, if we have a high-risk patient, someone that has long-standing disease or persistent inflammation, then screening with CMR would be useful much more earlier, I think so.
Yes, this case could suggest us exactly this, but as I mentioned before, we know from the previous two cases that ANCA-related vasculitis commonly could involve the heart. It's not so common, the heart involvement in giant cell arteritis. So we almost routinely look at the heart in case of ANCA-related vasculitis, but we not routinely look at the heart in the case of giant cell arteritis, yes. And this is, of course, a limitation, as this case clearly states, I think.
Okay, I understand that. But of course, when you have someone with persistent inflammation, I think that we should always think the heart, although it's very rare. But I think we all have seen very rare condition in all of our patients. Regarding your treatment, I think that you were very correct. The IL-6 is a very good therapy for those patients, and you also added mycophenolate, right?
Yeah, exactly.
I think that it was a little bit too late for this patient to
Yeah, probably
respond.
yes. Yes, I agree because I mean, it's probably the most probably biological reason for the lack of response because it's an IL-6 mediated disease. We know that anti-IL-6 should be affected. We also know from several other clinical contexts that mycophenolate is expected to be at least partially effective in virus negative myocarditis. So if you say that probably we get late here, we arrive late, probably the answer yes.
Yes.
But again, it's the unusual combination of myocarditis and giant cell arteritis with that was the reason for this diagnostic delay.
Would you consider JAK inhibitors? There are trials about
Yeah.
JAK inhibitors on large vessel vasculitis. We don't use them, but there are trials. So I think that a little bit earlier, if you have used them with caution, of course, you have to know the exact profile of the patient. Maybe you had the opportunity to take the inflammation more early.
Yes, that definitely yes. Even because the patient was on anti-IL-6 ineffective, it's not possible to, or it's not the best option anti-TNF because are not affecting GCA in general, and even with depressed left ventricular ejection fraction are not the best therapeutic option in this case. The patient received the placebo in the guselkumab trial, but we don't have so many data supporting the role of guselkumab in this clinical scenario. We can even use, in our experience, we sometimes use anti-IL-1 anakira, which is highly effective on myocardial edema, but there are not so many data to support the use of anakira in giant cell arteritis, so it could be effective for the heart, but probably not enough for the cranial involvement. So JAK inhibitors, which have a broad activity on multiple cytokine cascade, could be a feasible therapeutic option for sure.
We had a patient with psoriatic arthritis that also developed in some stage of the disease. She was under anti-TNF therapy and she developed myocardial inflammation, and we switched to JAK inhibitor, and she was the next CMR was very good. Okay.
Well, this is quite encouraging even for our case, for our patient.
But
Thank you for sharing.
it needs to be very well screened, the patient, who you are going to give JAK inhibitors. Okay.
Yeah, even because, as you know, JAK inhibitors in the elderly population with other traditional cardiovascular risk factors should be taken with caution. And this patient is 81 years old with hypertension, so it's not so many cardiac risk factors, but smoker, hypertension, old age. So it's yes.
If you consider that if he's a smoker or not, I also consider in those cases genetic testing for inherited thrombophilia.
Yeah.
I screen them, and I also do a carotid ultrasound before I give them JAK inhibitors. Just a suggestion.
Thank you for sharing even this suggestion.
Okay, so we can move on with Dr. Bratis and the next speaker, if we have another questions.
I can't see any questions from the audience. I would like to ask Professor De Luca a quick question about the clinical structure. So these challenging cases are discussed in a joint cardiorheumatology MDT meeting, or there is a cardiorheumatology clinic? What is exactly the clinical structure in your hospital?
We have a myocarditis disease unit, which is structured in our hospital. And in this myocarditis disease unit, we work together with monthly, bi-monthly meetings rheumatologists, cardiologists, basically rheumatologists, because they are responsible for endomyocardial biopsy. And there is a strong connection with CMR units. We, as probably you know, we had great expertise here, both in endomyocardial biopsy and cardiac magnetic resonance, and even with nuclear medicine, because we use PET-CT scan in this case of systemic vasculitis. We also try to use PET-CT scan for cardiac evaluation in case we cannot perform CMR, for example, patient with ECD, pacemakers, etc., with not so good results. So yes, there is a multidisciplinary team working together in this case of myocarditis.
Thank you. That would be my next and last question. So how often or when would you think of combining a cardiac PET in this case, in challenging cases, to combine the results of a cardiac PET and conclude whether there is persisting edema?
We try to. We have also a hybrid cardiac MRI PET-CT scan. We also studied in a formal protocol the performance of this hybrid cardiac MRI PET-CT scan. But honestly, sometimes we had discordant results between CMR and the cardiac PET. The cardiac PET is quite difficult to obtain because it's difficult to have completely fast glucose. It's not so sensible for patchy slight myocardial inflammation. And in clinical practice, we use PET in case we cannot perform CMR. And when we have a baseline PET, so patient with ECD, basically, we perform the PET at baseline, and then we use the PET to monitor if the PET is positive. If the PET is negative, it's a great big clinical problem.
Okay. Thank you very much. Thank you.
Thank you
for your presentation. So we have to amend slightly